Hello, my name is Talia Hoke and I'm a student at North Central University. Today I'm going to be talking with you about Virginia Woolf, depicted in the movie called The Hours, and combined other researched information to give a full picture as to why I diagnose her with generalized anxiety disorder in conjunction with major depression. So according to the DSM-5, she meets at least three of the characteristic symptoms that one needs to present with to be correctly diagnosed with generalized anxiety disorder, or GAD. She gets keyed up on edge very often. You'll see how she has almost like a short temper, and when she is unable to kind of move beyond whatever irritated her, she has jerky movements and tries to alleviate this anxiety or this irritation or being on edge by going out for walks. I think that one of the things that she did do habitually too was smoke a lot of tobacco, and that was self-medicating to try to decrease some of her anxiety. I already mentioned that she's irritable, very easily. She was irated by her staff, for example. She was irritated by the fact that they were kind of always around her. Some people would find that comforting. She found that irritating. So she would do little tiny things like send them on errands to very far places to get things that would take them all day to do. The day in which the movie took place, the main day, she was anticipating having her sister Vanessa and their children come to visit. To deal with her angst around her staff, one in particular she sent on an errand to London, which was at least a 2-hour trip in one direction from Sussex, where they currently lived, to get ginger candy for the children. So, that's an example of her being irritated and responding in a overt, not neurotypical way of dealing with her anxiety around her irritation. She also displayed irritation with regards to the doctors and her treatment. Often she mentioned how she was irritated because she wasn't part of the prognosis. She wasn't part of kind of trying to figure out how to move from plan A to plan B, or what the treatment plan would look like. She considered them stuffy, stuck up Victorian physicians that cared more about themselves than they did the patients. And often, again, voiced irritation around having to deal with them. She did speak to a little bit about how she had sleep disturbance, which is a third criteria for qualifying for having GAD, or generalized anxiety disorder. The opening scene, she comes downstairs, her husband's there to greet her in the middle room, and he asks her how was her sleep, and she said, uneventful, which I think was to describe just kind of restlessness, and she didn't kind of get the quality sleep that she needed to have a productive day. She often spoke about, or was often depicted in the film, that she had difficulty concentrating. Sometimes her mind went just completely blank. The example was prior to her coming down the stairs in the opening scene, you could see that she was preparing to write. And I guess for most writers, complete silence in a lack of disturbance is really kind of what's needed for them to be most productive. So she's spending all this time to try to get a first sentence, and she feels like she's just there. She's starting to write Mrs. Dalloway. She feels like she just has the opening sentence, and right when she feels like she's ready to take it from thought to paper, there's a knock at the door, and it's her servant. And immediately, she's unable to concentrate. Her mind goes blank. And there's another knock. So she's trying to ignore the disturbance, and it's a done deal. As is said and sometimes in what I was taught to believe, like Mexican culture around sleep, like your sleep was scared away, like her concentration was scared away. And that's something that both a little bit in the film, but then with some additional reading that I've done, I've come to learn that that was something that she kind of struggled with, being able to refocus after her concentration was broken. That was most of the things that were depicted in the movie to qualify her with general anxiety disorder. In doing additional research, I learned that as a child she had various nervous breakdowns. Her first one she experienced when she was 13, which is relatively young, when her mother and her brother died within a very short period of time. She went into this extreme state of depression, I should say, rather. And there wasn't really too much description as to what took place to qualify her as being depressed in terms of the little bit of research that I could do. It's just that that's what people said. She went into a state of depression. She was diagnosed as a young woman with nervous disorder. So when I Googled nervous disorder, I know that that was something that was used to describe what we consider to be anxiety disorder today. But that was what was used to describe anxiety disorder during the turn of the century. So late 18th century, beginning of the 1900s. This nervous disorder was also described to impede or negatively impact her social life, which is another criteria for having generalized anxiety disorder. Her father's death later on in life was her third major nervous breakdown. It was also, again, written that during these nervous breakdowns is when she experienced extreme depression. And I guess I'll talk a little bit more about that a little bit later. Oh, actually, right now. So the reason why I would give her comorbidity of depression with the general anxiety disorder is because her husband and whenever she expressed frustration around the servants constantly watching her and her husband constantly needing to know exactly where she was. She went out on a walk one day and didn't necessarily disclose or share to her staff, the service staff, or her husband, or any of his staff in the printing press that they had in their adjacent to their house, that he panicked. Everyone panicked because historically, when Virginia Woolf would disappear, so to speak, it was because she was experiencing a severe breakdown. So she would express kind of frustration around this babysitting, as it were, from the various people in her life. One of the things that Michael Yapko, author of Depression in a Clinical Update article, said is that the diagnosis of major depression can be tricky because depression is often masked or hidden by other coexisting conditions. These may be conditions such as anxiety disorder. So often people may present as just being depressed, but they actually have depression and anxiety disorder, or the depression is a result of the angst that they were feeling and how that negatively impact their life. So it's a common comorbidity that you'll see between anxiety disorder and depression. So my rationale for ruling out various other types of disorders that we were to look at this week, she doesn't necessarily meet the criteria for other anxiety disorders, such as separation anxiety, selective mutism. Obviously, in watching the movie, you'll realize that she's not making the decision to be mute for any reason when experiencing angst. I did get a little tripped up on social anxiety disorder. Honestly, that was what I initially diagnosed her with, because she did seem to be specifically anxious when interacting with other people, i.e. her staff. When her sister finally arrived and her sister wanted to know why she wasn't greeted at the door by her staff, Virginia said it's because she sent her into town to get ginger candy for the children. And Vanessa's response was, oh my goodness, Virginia, you can't be frightened of your staff. So, I was thinking that maybe she knew that her staff talked about her oddities behind her back. She knew that that was something that happened in high society as well. And so you could see her timidness in terms of interacting with people. And I initially thought it was because of this of social anxiety, but it's actually, I think, as I appropriately diagnosed her with general anxiety. It's not that it's mere socializing that's an issue for her. She also didn't present with having any specific phobias, even though her sister did say she was afraid of interacting with her staff. That wasn't necessarily a phobia. She didn't necessarily present as having what is necessary to be qualified as having panic disorder. Now, she did have panic attacks, which are different than panic disorder. The disorder would require for you to have a list of criteria that she did not meet. So that's why I didn't diagnose her with that. Pardon me. You could see, I think, that she was having kind of a panic attack about having to deal with her staff. And in her way of dealing with that attack was to send them away. But it's not a panic disorder. She obviously didn't suffer from agoraphobia, as you would see her go out into her community, go out for walks when she was trying to clear her mind so that she could refocus, so that she could write. And there was no talk of substance abuse in her life. And there was no talk of there being an additional medical disorder that would have led to her having an anxiety disorder. So that's why I ruled out all those other potential diagnoses and really just kind of focused on GAD as being the primary diagnosis with the comorbidity of depression. So my treatment plan would look like psychopharmacology. I think that it's important for a family therapist to become, just in terms of the reading, this is an assumption that I've gotten from the reading that I've done so far, but that MFTs need to become a little bit more comfortable with recommending pharmacology with certain pathologies. Graham, another author that we read this week, Michael Graham, spoke to how he would like, it would be more beneficial to get patients from a rattled state to a calm place so that they could concentrate on therapy, and that medication would allow them to be calm enough to learn breathing techniques, relaxation, and self-talk. This will enable them to master their coping skills. So before you can even talk about how to cope with your anxiety, you have to get the patient calm so that they would be willing to do the actual work. And 9 times out of 10, that's more beneficial with medication. So I'm not making this choice solely based upon my reading. I'm also making this choice based upon my professional experience as a social worker. I noticed that my patients or clients that presented with anxiety disorder did well or did better with combining medication with talk therapy versus just talk therapy. In terms of psychological treatment, most of the articles spoke to how cognitive behavioral therapy would work best to treat generalized anxiety disorder. Michael Carter said that in general, the goal of treatment is to influence the cognitive aspects of panic and anxiety by providing accurate information regarding the nature of panic and to teach specific cognitive reconstruction techniques that allow the patient to correct or modify the catastrophic conditions underlying the experience of these panic attacks. So, using cognitive behavioral therapies actually provides the tools needed for the patient to understand the underlying foundation of what's causing these panic attacks, or the generalized anxiety, I should say, rather. Michelle Carter, another author that we read this week, also speaks to how breathing techniques I apologize, can also help patients deal with their anxiety. She says the patient is taught to utilize diaphragmatic breathing to alleviate some of the psychological sensations resulting from panic and hyperventilation. The patient is also taught to engage in systemic introspective exposure in an effort to break the connection between the experience of psychological sensations and their fear response. So again, you want to look at CBT as being maybe a good theoretical base to work from when treating patients with generalized anxiety disorder. And both Michelle Carter and Michael Graham spoke to how breathing techniques would actually help patients go from extreme anxiety to manageable anxiety to no anxiety. It's also important to point out that Graham speaks to how once you get a patient to a place where they can function well with their anxiety, either because it's null and void or they have really good coping techniques, one of the things that surface are deeper issues. And once they surface, they need to be addressed. I think that this would be very interesting in looking at how that would take place in the family dynamic. That if you're looking at a wife or you're looking at a husband or a child that has anxiety disorder and then it's addressed, well then there are other issues now that child or that husband or that wife is now capable and able to not only address but see and recognize. So in thinking about how to do treatment as an MFT, one of the things that I would think about doing is working from the place of experimental theory, because that's what I gravitate towards the most. And Graham also stated that his focus, once those underlying issues surfaced, would shift from teaching client coping skills to helping them explore their values, goals, and intentions. Excuse me. So we have multiple opportunities or multiple ways to kind of look at addressing issues in within the family dynamic. The first thing I would do is discuss medications. As I said earlier, I would think that would be not only ethical, but the best way in which to cope, or the best way in which to begin treatment with the families, to make sure that the patient is at least at a position where they can start to learn new coping techniques. Once I got a chance to get a feel for the family dynamic, because cognitive behavioral therapy has been recommended so many times, I would look to see if I needed to shift my theoretical focus from experimental to CBT, or if I needed to incorporate other behavioral techniques. Actually, Michael Yapko had an excellent treatment plan for marriage and family therapists. He said that one of the reasons why they're so good is because they focus on identifying how things are better rather than why things are the way that they are. They teach relevant skills in concrete and highly structured ways. They focus on the future, not on the past. They emphasize action in the client's part, actively striving to change one's outlook on their behavior, and not just passively waiting for insight to occur in the neurochemical levels to increase. So I think that having an opportunity to utilize some of the techniques that MFTs have to offer in conjunction with, again, with either looking at the experimental method or CBT or a combination of the two would have really helped Virginia deal with some of her anxiety. It would have provided her husband with the tools he needed to be able to support her a little bit better. Some of the reading that I did indicated that he was actually a person that inadvertently supported her illness. He was kind of a scapegoat. And I think that was in part because he didn't know how to necessarily support his wife best. One of the things that broke my heart and breaks my heart in thinking about Virginia Woolf is that she wasn't a part of the treatment plan. And MFTs, we listen to the patient. We listen not only to what they feel their issue is, but also what they feel they need to get from point A to point B, and take that into consideration when coming up with an appropriate treatment plan, i.e. what I said earlier. Am I going to use experimental, or am I going to use CBT? If it's going to just be strictly cognitive, is it going to be behavioral strictly? So I'm going to figure out that based upon what the patient is telling me. And I think that had something to do with the Victorian era way of looking at psychotherapy during the time that the patient's perspective, opinion, feeling, thoughts wasn't taken into consideration when coming up with the treatment plan. Insofar as biomedical and a treatment plan around that, ECT, electroshock therapy, is something that I have seen professionally be productive. However, if Virginia Woolf and her husband were walking into my office, I would not at that particular point in time suggest ETC. It would only be suggested if we got to a place where I felt that there was nothing further that both medication and talk therapy could do to help this particular family and this individual. I would definitely pull on various supports to make sure that was an accurate suggestion to make before making it. I think it's a pretty extreme treatment plan, and needs to be used only in my opinion, as last resort. So there we have it. I would diagnose her again with general anxiety disorder, comorbidity with depression disorder, and laid out a clear treatment plan as a marriage and family therapist as how I would help her get her family from point A to point B. And so there we go. Should you have any questions, please feel free to email me at taliahoke@gmail.com, and note that the references will be attached to the bottom of this presentation. Thank you very much.